Hello and welcome to this lecture where I will be talking about the importance of growth and body composition following discharge from the neonatal unit until about 2 years of age. So in a previous lecture, I talked about the importance of nutrition on the neonatal intensive care unit, and I emphasized that if you don't provide enough nutrition during that stage, it's not possible to catch up on any deficits for brain development. So we need to make sure that we get it right the first time on the neonatal unit. We need to avoid malnutrition on the neonatal unit. And we need to remember that babies have one brain for life. And the focus of good nutritional care should be about optimizing brain growth in babies. I've also showed you some evidence that nutrition really does make a difference to brain development. There are studies to show that the amount of parenteral nutrition babies get in the first week of life impacts on brain development at 18 months of age. I showed you that lower energy intakes were associated with a higher risk of retinopathy of prematurity. There's also data from the studies of Anna Lucas and others showing that higher enteral macronutrient intakes over just a short few weeks on the neonatal unit is associated with measures of brain outcome at 16 years of age. And importantly, I emphasize that mother's own breast milk is a core component of neonatal care, and that the more mother's own breast milk we are able to give babies, the better metabolic and long-term brain outcomes we will see. So we can talk a little bit about the optimal patterns of growth. I don't plan to discuss in great detail different types of growth chart. You will all be aware that there are national growth charts. There is the WHO growth charts. There are growth charts from the Intergrowth 21 collaboration. And then there are the Fenton growth charts. All of these growth charts were created differently and have different strengths and weaknesses. And really, this has to be a decision for your own units about what growth charts are available nationally. So I don't think we can make an easy statement about which growth charts we should be using. But it's important that you do use a growth chart rather than just calculating the numbers. We might want to think a little bit about the ideal body composition after post-discharge, and we will also think a little bit about the impact of catch-up growth on neurodevelopment. So I want to emphasize that there's a lot of variability in growth, and faster growth patterns are not always better. The growth patterns of infants with a good and a poor outcome overlap. And this is true for both brain and metabolic outcomes. So it's not possible to accurately define normal and abnormal growth. Slow growth in a healthy infant is frequently acceptable. Rapid growth in an at-risk infant may indeed be harmful. So it's very difficult to explain what is the best growth pattern for an individual infant. The key question in the follow-up period is the infant healthy? If the infant has bronchopulmonary dysplasia, a brain injury, or a stoma with higher needs, then the growth pattern might differ. We need to involve parents, take a clinical history, work out what the typical diet is, how much breast milk the baby is getting, what medications the baby is on, and also examine the baby in terms of determining what is the healthy growth pattern. If an infant is growing slowly but appears healthy on examination, and especially if she or he is breastfeeding, then 99% of these cases of slow growth do not need to generate any major concern. And there's little evidence that promoting faster growth after discharge is beneficial. However, that may not be true in unhealthy infants who are unable to regulate appetite or energy intake. So, for example, babies with a brain injury. And that may not apply to unhealthy infants who are unable to consume what they want. For example, infants with lung disease who may be too breathless to feed adequately. The developmental origins of health and disease describes the relationship between early growth in fetal life or early neonatal life and later metabolic outcome. So this is the so-called Barker hypothesis or metabolic programming. So infant growth is associated with metabolic outcomes. However, this association exists on a population level and might be confounded by multiple other factors, for example, social factors, parental factors. The causation is not clear. There are likely to be multiple mechanisms associating early growth and later outcome, for example, hormonal mechanisms, epigenetic, genetic effects. The population effect size is important, but often this is actually quite small. So the effect on an individual baby of the growth in infancy and later life may be really quite small or even non-existent. What else is associated with outcomes, brain outcomes in these babies, in addition to growth? Well, we know that maternal diet, both before and after conception, might be important. For example, vitamin D, fatty acids. There are likely to be a whole range of epigenetic effects, perhaps in the mother's previous experience prior to getting pregnancy. We know that maternal BMI and adiposity impacts on fetal and neonatal growth. There are likely to be genetic factors. Importantly, we know that there are socioeconomic determinants of health. So parental education, lifestyle, and physical environment have a big impact on metabolic and cognitive outcomes. And there may be a range of maternal diseases. So we are interested in infant growth, but we must remember that the impacts on the baby and the brain and metabolism are much more than simply growth. In addition to all of those factors that I've talked about that apply to all babies, in preterm babies, we know that some babies suffer from necrotizing enterocolitis and the cytokine storm. This appears to damage the brain, particularly the white matter, and I will be talking about that in a later lecture. Some babies unfortunately develop intraventricular hemorrhage or cystic periventricular leukomalacia that clearly has a big impact on brain growth. There may be inflammation associated with lung disease. We know the stress of being on a neonatal unit ex utero, light, noise, lack of kangaroo mother care, inappropriate sensory impacts impact on brain growth. As I've said, sadly, we see many babies are malnourished during their time on the neonatal unit. And as I emphasized in the previous slide, the home environment has a major impact on outcome in babies. So there are multiple other factors impacting on brain outcome in infancy in addition to growth. Now, there is an association, but causation has not really been proven. So it seems that people imagine that poor nutrition leads to slow growth and that slow growth leads to worse outcomes, but this is not correct. We know there are a whole range of other factors that I've just described, genetic factors, maternal factors, and it's these factors that lead to slow growth. And independently, these factors may result in worse outcome. But there is not a causation between growth per se and worse outcomes. So when does slow infant growth require closer inspection? Well, for babies who have a weight outside normal for more than 2 standard deviations below the mean, especially if length and head is below the mean, we need to watch these babies carefully. We need to watch for babies where weight gain is not parallel to the centile. It's not easy to define that. Often, if weight gain drops more than 1 standard deviation, we might be concerned, but often this is still normal. And a drop of 1 standard deviation score for babies born on the 50th centile is really quite common. But if a baby is only born on the -2 standard deviation score and drops to -3 standard deviation score, that's likely to create much more concern than a baby who started on the 50th centile. So we need to look at the growth chart and not focus too much on grams per day. In the UK, we have these very useful growth charts that are very appropriate for very premature babies because they provide you weight and length and head trajectories starting from 23 weeks and going up to 2 years of age. And this is the so-called UK WHO dataset. When we look at these growth charts, we can compare different growth trajectories and work out what might be appropriate. So here again, I show you babies who lose 1 standard deviation score. And babies who start in the green level are going to generate less concern than a baby who started on the red dots, who is already on the 2nd centile and loses further position. Compare these two trajectories. In red, I show you a baby who loses 1 standard deviation for weight. But if you look at his length in red and his head, we can see that length and head gain is preserved. So maybe this baby in red is actually doing okay. In contrast, the baby in blue who started off at a higher position for weight is demonstrating poor linear growth and poor head growth. And so this baby in blue is likely to generate much more concern. So measurement of length and head helps interpretation of growth. Remember that growth is what we call saltatory. It doesn't grow in a linear fashion. Babies have a little growth spurt and then pause. So this makes it impossible to make meaningful interpretation over very short time periods. On the NICU, I think you need a 5-day growth period to really have any chance of assessing growth. And after discharge, you need probably at least a 10-day period to assess growth, maybe even 2 or 3 weeks later in infancy. But you can see here that if you interpreted growth on a day-to-day basis, you might get concerned the baby was growing too slowly. But then on days 3 and 4, you see that she's losing weight and appears to fail to thrive. So really, we need to measure weight gain over several days before we can interpret growth. So length and head are important to interpretation, but measuring length is challenging. With a poor technique, you are likely to get an incorrect interpretation. So unless you have a good technique, it's better almost not to measure at all. So poor technique area can easily cause a difference of about 2 centimeters in length in your post-discharge clinic. 2 centimeters is equivalent to about 6 weeks of growth. So when you measure length, make sure you use a good technique. You need a robust measuring board and 2-person technique. It is not acceptable to measure growth using a tape measure. You will simply get an erroneous value. So 2-person technique, you need a bit of practice, you need a relatively cheap length board, and you need a period of at least 7 days to assess length on the NICU, and post-discharge probably a longer period. Why should we measure length after discharge? Well, there are at least 3 good reasons. The first is that if weight gain is slow, linear growth might provide reassurance that lean mass secretion is continuing. If weight gain is fast, it might indicate excess fat mass secretion. But most importantly, measuring length makes people think about the importance of growth and in nutrition. However, we can use length in later life to calculate BMI, body mass index, but this is not a useful measure in preterm babies, particularly on the NICU or after discharge. Often we see that in the first few weeks, infants gain weight and head before linear growth starts to occur. So in the first few weeks of life, babies appear to have a lag in length gain and may therefore appear to have a high BMI, whereas in fact, probably the accumulation of fat is appropriate. So BMI is a very poor predictor of fat mass in an individual infant, and BMI is also a measure of lean and muscle. So do not restrict energy intake if the BMI is high. Better, as I say, don't calculate BMI, just look at the growth chart. So measurement of length and head is important. It should be a routine component of growth monitoring. Single measures are not helpful. We need to interpret the pattern over time using a growth chart. So we need repeated, accurate measures. And we should interpret this alongside the weight trajectory. Appropriate growth means an increase in weight and length, but also an appropriate body composition. So, how can we assess body composition in infancy? Well, there are multiple different methods that can be used to assess body composition, and I'm going to go through these one by one. However, most of these are only useful in research settings, and I don't think that more complex measures are needed in clinical practice. Mid-arm circumference is useful in childhood as a measure of malnutrition. It's not affected by edema, it's easy, it's reproducible, it's very cheap, and there are references that exist. And there is some correlation with percentage fat mass measured using air displacement, plethysmography, or DEXA. So mid-arm circumference may be useful in some situations. However, there are limitations. There are limited references for preterm infants post-discharge. The mid-arm combines both lean mass and fat mass, so it doesn't really tell you about adiposity. Skin fold thicknesses have been widely used, again, relatively cheap, relatively accurate. It does reflect total fat mass. They are feasible, reproducible, and there are reference ranges for bigger preterm infants. And the percentage fat measured using this technique does correlate with air displacement, plethysmography, and DEXA. However, there are limitations. It doesn't reflect intra-abdominal fat, which might be the major risk for later obesity. It may be affected by hydration status, and there are no references for extremely preterm infant. And also, skin fold thicknesses give you very little information about lean mass. For those of you who have done the skin fold thicknesses, you will also realize that they are uncomfortable and many babies don't like it being done. Ultrasound can be used to measure visceral and subcutaneous fat. It's not complex to do, and it's relatively safe. But again, there are many limitations to its use. So, first of all, we need an ultrasound machine, which may not be available. The operator needs to have a certain amount of skill, and therefore this makes it a relatively expensive technique. And therefore, it's not widely used to assess body composition. Air displacement plethysmography uses a machine called a P-pod or a body pod in children. The baby is simply placed inside the machine, the air is pushed in and out, and the displacement of air by the body allows body volume to be calculated, and then combined with weight can provide an estimate of fat mass. So this does correlate reasonably well with other techniques, including isotope dilution, and it's widely used in research studies. It's very safe and easy to do, but again, there are limitations. There's no information about where that fat is deposited. It doesn't tell you whether the fat is in subcutaneous tissues or intra-abdominal fat. There are size limitations using the P-pod before you would need to move to the bigger pod. And the infant has to be able to be placed inside the machine to have it measured. Some babies find it disturbing, and you can't do this in a baby still connected to oxygen or ventilators. And there are limited references for babies born less than 2 kilos. Dual X-ray absorptiometry, DEX machines are widely available. It does give you a measure of fat distribution. It's relatively reliable and widely used, and it does seem to correlate with fat mass and fat-free mass using MRI. However, there are important limitations. The accuracy of where the fat is distribution is a bit limited. Again, the infant has to lie still to have this done, and there is a small, very small radiation exposure. MRI might be considered the gold standard. This gives you measures of whole body and regional fat distribution. So it allows you to measure subcutaneous, visceral, and abdominal fat. It's reliable and reproducible and doesn't involve any radiation. However, again, there are major limitations. This is a very expensive technique. Babies need to lie still inside an MRI scanner. It's very noisy, so they need ear protection. And there are limited references, so it's not widely used outside of research settings. Bioimpedance analysis measures total body water. This estimates fat-free mass. It's very quick, portable, non-invasive, pretty cheap, and it does correlate in childhood with fat-free mass. However, again, there are important limitations. The accuracy is a bit questionable. It may overestimate total body water. The position of the electrodes, particularly in small babies, makes a big difference to the measures, and there's no information on where that fat is distributed. Furthermore, there's no reference data in preterm babies. Isotope dilution measures total body water, gives an estimate of fat-free mass. It's very accurate and reliable, and it's actually very safe. But again, there are limitations. It's relatively expensive to use. There's no information on fat distribution. There are limited references in preterm babies, and some parents are alarmed by the term isotope, even though these are stable isotopes with no radiation risk. So there are multiple methods to assess body composition, but my own personal opinion is that I don't think we really need to use these clinically, but they may be important in research settings to help us understand the impact of nutritional interventions. PPOD and DEXA may be used sometimes in clinical settings. I have my doubts as to how much they really help. But again, as I say, there are lots of limitations because the MRI gold standard is very expensive, and there are other concerns about the reliability and validity of these measures. However, there have been a number of research studies, and what do they tell us? They tell us that there's actually better lean mass secretion with higher nutrient intakes, particularly for protein. We know that lean mass secretion is associated with head growth and neurodevelopment, and the knowledge of body composition, as I say, I think might help in a research setting. So how similar or different is fat mass in preterm versus term babies? Well, if you look at fat mass at a corrected age of 40 weeks, you'll see that in many preterm babies, this is somewhere between 15 and 20% compared to an average of about 11% in term babies. And this might lead many neonatologists to have a concern that we're making babies too fat. However, if you measure fat mass at 3 months of age, it's actually pretty similar between preterm and term babies. Term babies show rapid fat accumulation after birth, just like a preterm baby, with a slight decrease to around about 22% fat average at 2 years of age. So preterm babies experience rapid accumulation of fat mass after birth. There are several possible reasons why this may occur and why it might actually be an advantage. So fat mass provides warmth, it provides mechanical protection when the baby is outside the uterus. It may be a response to stress, but there's also evidence that in humans we're programmed to store fat in order to protect the brain from a lack of energy if there's an acute period of starvation. Now, we often say that the aim of preterm growth is to grow similar to the fetus, and really this isn't possible. What we should say, I think, is that after the early fluid loss caused by fluid redistribution and less loss of extracellular fluid, we should aim to keep the babies on the weight centile that they are on at about day 7. Length, as I say, takes time to re-establish, and fat mass secretion will be much higher than the in utero fetus. So if we look on the left at preterm babies in red and term babies in blue, these are the measures from different research studies. Along the x-axis, we have postmenstrual age, and on the y-axis, we have percentage fat mass. And as I say, what we can see is that at 40 weeks gestation, preterm babies are fatter than term babies, but by 3 months of age, there's really not very much difference at all. So later in life, overall BMI is similar between preterm and term babies, although there may still be differences in adipose distribution. If we look at fat-free mass, so this is really lean mass, muscles, brain, organs, plus a bit of bone mass. Again, we see important differences. So preterm babies have lower fat-free mass at 40 weeks corrected age, about half a kilo difference. But by 3 months corrected age, there's been a lot of catch-up. So there's only a small difference, although there is still a difference. So most preterm babies seem similar to term babies by 3 or 4 months of age. And there is then slow catch-up over the first 1 to 2 years of life. I just want to go back to thinking about the impact on neurodevelopment. We've said that malnutrition on the neonatal unit is common due to lots of different reasons, including feeding problems and low nutrient intakes. And these may both cause worse neurodevelopment and slower growth. But there is no link between the slow growth per se and worse neurodevelopment. And babies also have higher nutrient demands, perhaps for repair of brain injury and other tissues. And in babies who are unable to upregulate nutrient intakes, this may also lead to worse outcomes. So nutrient intakes determine outcomes. Growth is just a marker rather than a cause of later outcomes. So how does nutrition impact on brain development? Well, there are multiple different mechanisms. We need nutrients for tissue substrates. We need all the macronutrients and micronutrients. We need energy to drive the system from carbohydrate and lipids and perhaps protein sometimes. Nutrition provides lots of signaling and growth factors, particularly phospholipids, sphingomyelins, hormones, such as IGF-1 and epidermal growth factor. Certain nutrients are involved in gene expression. That's true for folate, B12 iron, DHA, choline, but potentially other nutrients as well. We know that breast milk is associated with lower rates of necrotizing enterocolitis, sepsis, retinopathy, and BPD. All of those are associated with brown outcomes. And then there's the important area of the gut-brain axis, so particularly prebiotics such as human milk oligosaccharides, maybe lactoferrin, and probiotics. So what are the mechanisms linking nutrition to brain outcome in infancy? Well, in post-discharge period, there's limited elements from randomized controlled trials. We have explored the impact of nutrient-enriched formulas and breast milk fortifiers and fatty acids, and we're going to go through some of that data next. Many studies show that faster infant growth is associated with larger brains or cognitive outcome, but this may not be causative. This may simply be association. Now, many years ago, I conducted studies looking at the impact of different nutrient regimes following NICU discharge, where we were particularly interested in growth and body composition. So in these studies, babies were randomized to different types of formula. So this excluded generally breastfeeding babies. And we provided different amounts of nutrients in these different formulas over the first 6 months of life. But what we found at 2 months of age was that the type of formula had pretty little or no impact on infant neurodevelopment. And we were then able to follow these babies at 10 years of age. When we saw these infants at 10 years of age, what we found was that there was a very small effect of a preterm formula, suggesting that high nutrient intakes might have some effect. We also saw that faster weight gain over the first 12 weeks was associated with higher IQ and also higher perceptual organization. But remember, this is observational data and not causation. Head growth was also associated with full-scale IQ and freedom from distraction. So we were unable to see any impact of an enriched formula, but we do see these important associations of early growth, early weight gain and head growth on cognition 10 years later. So nutrition clearly is associated with outcomes 10 years later, but many of these are associations rather than causations. This is what the data look like. On the x-axis, we have change in head standard deviation score between discharge and 6 months of age. And you can see this clear association with the full-scale IQ and perceptual organization. But what about adverse metabolic programming? Well, in term infants, rapid growth seems to be associated with worse metabolic outcomes, and there's no evidence of any cognitive benefit. In preterm infants, faster growth have inconsistent relationships with later metabolic outcomes. Some studies do show an associated with better cognition, but the mechanisms are complex and poorly understood. It's likely that socio-demographic and family dynamics have an important impact on this. There may be some small effects of higher protein on IGF-1, but there's many other complexities, including the time of introduction of complementary foods. So again, I showed you this study before where we randomized babies to 3 different types of formula. And we also had other studies that we started off at an earlier stage. And we were able to combine all of these to look at the impact of growth on metabolic outcomes at 11 years of age. And we looked at metabolic outcomes, including body composition, insulin sensitivity, and we also included physical activity and dietary questionnaires. And we've then also been able to do some outcomes at 16 years of age using MRI, looking at muscle activity. So I'm going to present to you here the outcomes at 11 years of age. And there's a huge amount of data here, and I don't want you to look at it in detail. I'm just going to summarize it very briefly. But we adjusted all of these outcomes for sex, age, birth weight, Z-score, gestation, and illness. So what we see is that change in weight Z-score on the NICU or in infancy has virtually no impact on later metabolic outcomes. So this is the first box on the left. When we look at the impact between discharge to term or term to 12 weeks, we also don't see very many differences. Only when we look at the change in weight between 1 year of age and later childhood do we see associations with metabolic outcome. So change in weight after infancy has a significant impact on adolescent metabolic outcomes. And greater or worse adiposity is associated with later fat mass percentage, fasting insulin, blood pressure, lower cholesterol, lower HDL, and higher cholesterol to HDL ratios. So infant growth seems to have relatively little impact on later metabolism compared to childhood. And this may be due to lots of different factors, including social, lifestyle aspects, dietary aspects, and genetic aspects. So just to emphasize again, preterm infants are vulnerable. Good nutrition is vital. They have one brain for life, and growth is a marker, not an outcome. On the neonatal unit, macronutrient intakes and mother's own breast milk improve outcomes. Body composition is important but difficult to measure in practice and differs in preterm babies. But post-discharge growth is associated with long-term cognitive outcomes. But I don't think we need to be too worried about patterns of growth in the first year of life, because this has much less metabolic impact than childhood weight gain. I've emphasized that there are multiple pathways impacting on growth and outcomes. But importantly, again, I want to emphasize that it is not growth that leads to these outcomes. It's all of these other factors. So what might be the associations between nutrition and long-term neurodevelopment? Well, yesterday I showed you this picture of brain growth spurt in humans. And so we can imagine that if there's nutrients A, B, and C, where there is a deficit, these may have a different impact on your cognitive phenotype. So the impact of a nutrient deficit depends on the amount of the deficit, the type of nutrient, the timing of the deficit, and the duration. And remember again that nutrients do not work in isolation. All of these need vitamins, enzymes, and energy. So scenarios A, B, and C may all result in different neurocognitive phenotypes. And importantly, we need to be interested in later life effects, not just those effects that occur at the first 2 years. So we want to be interested in language and processing speed and all these different things. So all of this is very much more complex than simply doing a 2-year Bailey assessment. We need to remember that the 2-year Bailey was not designed to test the outcomes of nutritional interventions. It's quite possible we're missing important impacts at 2 years of age because the test that we're using is not sufficiently robust or valid. So you might want just to take a few seconds now to think what might be the important nutrients after discharge. Do you know any nutrients that you think are particularly important after discharge? Are there any nutrients that perhaps we don't need to bother so much about after discharge? Well, now you've had a chance to think. Of course, proteins can be important, but so is energy, lipids, essential fatty acids, iodine is important, iron's important, choline, zinc are important, selenium might be important, water is of course important. So actually, which nutrients are not important after discharge? Well, the answer is that every nutrient is essential for the brain. If you provide everything in perfect amounts, but you miss out one nutrient like zinc, all of those other nutrients are not going to be able to work. So when we think about post-discharge nutrition, we know there are multiple cellular outcomes, such as on adipocytes and myocytes, metabolic control, brain growth. We know that there are lots of social and behavioral outcomes that are important. So studying this is very complex. We've talked about the practical relevance, the importance of taking a good dietary history and looking at the supplements. Usually, I think the amount of protein provided in breast milk or term formula is going to be sufficient. I don't see evidence that babies need more protein after discharge. There's probably enough fat and carbohydrate also available there for babies, although we are going to talk about the role of docosahexaenoic acid in a subsequent lecture. Water, remember, water is an important nutrient, and so we should be careful if we're using a very nutrient-dense formula if the baby has excess fluid losses. So if the baby is on a nutrient-dense formula and suffers from acute diarrhea or has an ileostomy or extreme heat, these babies may need extra free water. But if babies are breastfeeding, then there will be sufficient water in breast milk. We've talked about the fact that babies with a lung or brain injury may require different amounts. So it's possible that these babies may benefit from a specialized formula if breast milk is not available. And there have been studies looking at breast milk fortifier, which I will discuss. Now, remember that in all babies, we need micronutrients, vitamins, and trace elements. All babies less than 2.5 kilo birth weight probably need a bit of extra iron during infancy. All these babies need extra additional vitamin D, but there's no evidence to support other routine supplements. Now, there are different formulas that could be available after discharge. We could use a preterm formula, especially designed post-discharge formula, and we might want to use breast milk fortifiers. I'm not going to go through this in detail, but these Cochrane reviews compared the impact of a post-discharge formula compared to a standard formula, or a preterm formula, PTF compared to standard formula. And these do show slightly higher rates of weight and length gain when you use an enriched formula, but no beneficial impact on brain development in later life. The use of breast milk fortifier has been used after discharge, has been studied in 2 randomized controlled trials. Overall, these really don't show significant impacts on growth, although a small Canadian study showed slightly greater visual acuity in the first few months that I don't think was maintained. So overall, I don't see evidence of important functional benefit from the routine use of breast milk fortifier, but this might still be useful in 1 or 2 exceptional cases. So overall, no benefit on functional outcomes from enriched formula, but specialized formula may be useful in complex babies such as those with chronic lung disease or those with a brain injury. Again, I want to emphasize the benefits of breast milk. Here on this graph, you see 4 groups of babies. These babies got no mother's milk on the neonatal unit. These babies got mother's milk on the neonatal unit. These ones got breast milk until 2 months of age, and these for more than 2 months of age. And up the y-axis, we have the Kaufman ABC. And what we see is slower growth in babies who are breastfed, but better brain outcomes. This is the so-called breastfeeding paradox. Again, energy intakes are usually sufficient for most formulas and breast milk, but there may be babies with additional energy demands, such as those with lung disease or heart disease, that may need extra energy. And there may be some babies with brain injuries who may benefit from higher energy intakes. Now, this hasn't been well studied, but there is some evidence that extra energy after discharge might be beneficial in those with a brain injury. Now, this was a very small trial, just 16 babies who were preterm or had hypoxic ischemic encephalopathy, so they had good evidence of a significant brain injury. And they were randomized to getting 20% extra macronutrients after discharge. And they looked at the impact on weight, length, head, and axonal growth measured using magnetic stimulation, which is a test of neuronal speed of conduct, so a measure of axonal growth. So here we see the 2 groups. So this is the decrease in head score, and this is the age of life, 3, 6, 9, and 12 months on the x-axis. And this is the head circumference standard deviation score. And what we see is that in the non-enriched group, there's loss of standard deviation scores for head. But when they measured axonal growth in babies, what they saw is that in the enriched group in red, they saw much faster axonal growth in the babies getting 20% extra macronutrients, protein, and energy. Now, this study's never been repeated, but to me, it's quite interesting. It does suggest that in some very complex babies, there may be an advantage to giving extra nutrients, but that might involve the use of nasogastric tubes. So where infants are healthy, their energy needs are usually met. Let the baby regulate themselves on energy, but in babies who are unhealthy, specialized formula or supplements may help. So we know that gene expression is important. We know there are lots of epigenetic mechanisms for compounds such as folate, iron, and fatty acids. And there are lots of components in breast milk that might be important, such as hormones, enzymes, and human milk oligosaccharides. I mentioned some of these yesterday. Formula will never replicate breast milk, so a lot of our efforts should be focused on how we best support mothers. Remember again that iron is important for brain development. It's critical for neurogenesis and signaling. And breast milk is naturally low in iron. It has sufficient iron for term babies, but if you're born small, less than 2 or 2.5 kilos, you probably do need extra iron supplements. The gut-brain axis is very important. I don't have time to discuss this in detail, but we do know that components of breast milk might be important in acting on the brain. But there's no evidence that probiotics or other interventions like this are beneficial after outcomes. But there are lots of different mechanisms. I think I told you before that depending on what's in breast milk, you impact on the types of bacteria living in the gut. And all of these bacteria in the gut produce different compounds, which may themselves be impacting on brain development. We know in adults that the gut-brain axis impacts on appetite, gut motility, so it may impact on things like colic and stool softness in babies. It may be involved with production of growth factors, the brain connector. It may be impacting on sleep patterns. So the gut-brain axis is very important, but we don't understand enough about this to make any recommendations. However, I like this very small study from almost 20 years ago now, where they looked at 8 babies who were breastfed and 8 babies who were formula fed. And in breast milk, they measured the level of tryptophan, which is a precursor of melatonin. And then in the urine, in both the babies who were breastfed and formula fed, they looked at this metabolite 6-FM, which is a metabolite of melatonin. And as well as collecting the urine, they also put little sensors on the baby's wrists to look at patterns of sleep. So a very nice study, but very small numbers and never repeated. And what they showed was that actually sleep and sleep efficiency was better in breastfed infants. So what we see in breast milk babies is that tryptophan peaks in the early hours of the day, and that breast-fed babies' urine, the melatonin levels peak at 6 in the morning, suggesting that babies get the higher peak of melatonin when they're sleeping or when we want them to be sleeping at nighttime. Whereas when you look at the peak of melatonin in formula-fed babies, the peak of melatonin happens in the middle of the day. So some evidence here that patterns of melatonin and sleep hormones might be better in breastfed babies. Now, just finishing off to pick up nutritional status in infancy. Well, nutritional status is what you eat, what you are, and what you can do. And we can think about how we might want to assess this based on some of the things we talked about earlier. So when we're assessing a nutritional status in infancy, we should think about the dietary history, whether the mum's breastfeeding or formula feeding, what supplements the babies are taking. We need to think about weight, length, and head, and whether they're in proportion, maybe body composition in some specific settings. And then we think about what the babies can do. So we need to make an assessment of the babies, make a distinction between healthy and unhealthy babies, and think about the importance of lung disease and brain injury. So assessing nutritional status and improving the outcome, this requires a broad multidisciplinary team, and we need to think about all of these different aspects and work with parents. And we can do this, as I say, using the ABCD approach, where we think about the importance of anthropometry. Bloods and biochemistry are very rarely needed after discharge, occasionally perhaps in babies on iron supplements who are at high risk. Maybe babies looking at minerals and electrolytes if there are high doses of diuretics, but generally you don't need to measure bloods and biochemistry. We need to think about the clinical status of the baby. We need to think about the dietary intake of the baby, what types of milk and what supplements the babies are getting. And then we need to think about the environment and evaluation, recognizing that the family and home environment have a major impact on how these babies are going to eat. Reassure parents that the absolute centile position does not matter. We just want the growth to be approximately parallel to the lines in the growth chart. So there are lots of different compounds in breast milk that impact on brain development, and it is impossible to replicate these in formula. So just to finish off, a few quick case studies to think about. So here are 3 babies, A, B, and C. Here's their weight. Just have a little think which babies you think are most healthy. Well, the answer is that a single measure of weight is not helpful at all. It's not going to tell you how the babies are doing. Let's look at these 3 trajectories. Here's a green baby decreasing, here's a blue baby increasing, here's a red baby on the bottom line. Which Which of these babies is most likely to get metabolic syndrome, or which of these babies is most likely to have a poor brain outcome? Baby A, B, or C, or all of them? Well, the answer is that all of these weight gains might be normal. You can't predict the outcome for an individual baby. So a 34-week baby born at a big weight because the mother was diabetic might normally naturally lose a bit of weight over the first few weeks. This baby here, a 30-weeker breastfeeding on discharge, appears to be increasing in weight. This growth retarded 30-week baby who's formula fed seems to be maintaining the center. So weight gain is hugely variable in healthy infants, and we shouldn't be overly concerned about different patterns of growth. Look at this baby, born at 26 weeks, ventilated for 4 weeks, discharged in oxygen on a standard term formula. The baby is now 11 weeks post-term, weighing 5.5 kilos. The baby's drinking 80 mils of formula 5 times a day. The baby's getting 2 milligrams a day of iron, vitamin D of 400 units, and the parents have no concerns. What do you think about that growth chart and the nutritional status of that baby? Again, I'll just give you a few seconds just to think what you might want to do with this baby, or what you think about that growth chart. Think about the iron supplements. Well, typical formula in term formula, iron content has about 10 milligrams a litre. So 400 mils of milk will only give 4 milligrams of iron. And we think that babies at this stage need around about 2 milligrams a kilo of iron. So this baby needs about 11 milligrams a day of iron and is only getting 2. So I would say that the growth patterns look fine. We can be quite reassured by that, but we need to remember the importance of iron. So this baby needs actually a higher dose of iron supplements. Here's another baby, 26 weeks, needed dexamethasone to help the baby off the ventilator. Discharged at 38 weeks corrected age, weighing 2.4 kilos, discharged on 50 micrograms a kilo a day, 50 micrograms total dose a day of dexamethasone. Baby's only on 0.1 litre and formula feeding. The baby's now 12 weeks old. Remains on dexamethasone, a good intake of iron, 10 milligrams a day, good intake of vitamin D, good saturations, and the parents are not concerned. So just have a look at that growth chart. Think about the supplements, think about the medicines. What do you think about that baby's growth pattern? Do you have any concerns? Would you change the management at all? The parents are happy, the baby looks fine. Well, in this case, I think the growth looks acceptable. The weight gain's a bit faster than length gain, but I don't think I would be bothered about that. But that might be due to the impact of steroids. So my plan in this baby would be to wean or stop the dexamethasone. I don't think the baby needs lots of oxygen. Here the saturations are 99%. So I would wean the dexamethasone, make sure the baby's okay, measure the saturations again, and then think about stopping the oxygen. But I would simply continue with formula feeding, iron and vitamins for a bit longer. Here's a baby. He looks a little bit unhappy. Born at 26 weeks, had CPAP, breast milk and fortifier, discharged weighing 2.5 kilos at 40 weeks, getting appropriate amounts of iron, vitamin D, and a little bit of nasal oxygen. And 2 weeks later, he weighs 2.6 kilos, so he's only gained 100 grams in weight over the 2 weeks since discharge. Mum says he's breastfeeding well, he's normal to examine, his oxygen saturations are good. So the parents are concerned about the slow weight gain. What are you going to do? Perhaps you might want to give a specialized formula. I don't think I like that idea. I think I would like to continue with breastfeeding. Maybe you're going to say, well, the baby's absolutely fine. Maybe I just see what the baby's like in another 2 weeks. Maybe that measurement period was a bit short to accurately assess weight. I think that would probably be my preferred option. Maybe some people would see in 4 weeks' time. That might also be okay. Some people might think about increasing the amount of iron. Let's check the baby's on the right amount of iron. I don't know how much baby is getting. Some people might suggest continuing the breastfeeding, but adding in a couple of feeds of bottle formula per day. Again, that risks adversely impacting on breastfeeding, but some people might do that. Some people might think about starting a breast milk fortifier after discharge, but there's no evidence to support that, and breast milk fortifier may not be available. So I can't tell you what's the right thing to do here, but you need to explain things and involve parents in making a decision that feels right for them. Here's another baby, 26 weeks, was on CPAP. On the neonatal unit, the babies always had vomit in the mouth, and so the baby was started on omeprazole. And otherwise, the baby remained well, went home at 38 weeks, corrected age. And the baby's on iron, multivitamins, omeprazole, breastfeeding well, just a small occasional vomit, 12 weeks post-term, and the parents want to start solids. What would you advise for this baby here? Well, I think the growth looks acceptable. I would encourage the mom to continue breastfeeding, iron and vitamins. I would say there was no need to start solids, but also no harm if the parents wanted to start solids at this time. I wouldn't stop them from doing that. But I would stop the omeprazole. There's very little evidence for the use of omeprazole on the neonatal unit and very little evidence for use after discharge. Omeprazole raises the gastric pH, which impairs calcium absorption. This interferes with bone mineralization and also increases the risk of fractures. So I would have stopped the omeprazole before the baby was discharged. In fact, I probably would never have started it in the first place. Here's a preterm baby born at 27 weeks, discharged at 38 weeks in oxygen. And the family doctor had prescribed some hydrocortisone for a rash and also tried out some clotrimazole in case this was a fungal infection. The baby comes to clinic 2 weeks later. The weight's falling the centile. The baby's in low flow oxygen. The baby's on multivitamins and iron. But the hydrocortisone and clotrimazole did not improve the rash. And this is what the rash looked like. And this was a baby that I looked after about 25 years ago. So a bit of a rash here on the wrist, rash here on the kind of neck and chin, but also some rash in the scalp. So I can understand why people thought this might be eczema or maybe tinea. Actually, what we found when we measured the bloods was that the baby had a very low level of zinc, and the baby also had a very low level of phosphate and high calcium, perhaps indicating the baby was not getting sufficient minerals. But importantly, the baby had a very low alkaline phosphatase. I would have expected this to be much higher in an ex-preterm baby growing quickly. So what was going on here? As I say, probably this was explained by the low level of zinc. I prescribed the baby some oral zinc supplements. We stopped the creams, and within 2 weeks, the baby no longer needed oxygen, and the repeat level of zinc in the bloods were normal. Now, this is the only time in my whole neonatal career where I felt like I'd almost performed a miracle. But when I looked at the bloods, I saw the alkaline phosphatase was now very high, suggesting that rapid bone growth was happening. Now the baby had sufficient zinc. And remember that zinc is required for lots of different enzymes. So I was interested to measure the zinc in mum's breast milk. Why was it that this baby was otherwise healthy? And when I tried to take milk from the mum, she said that she had also started taking the zinc because she thought she might be zinc deficient. But luckily, we had stored breast milk and we were able to analyze that. And that mother had a particularly low level of zinc in breast milk. We don't know why. It seems to be the case. And I wrote that up if you want to read that paper. So in summary, for nutrition, get it right on the neonatal unit. You only have one brain for life. Growth is a marker, not an outcome. Nutritional status is much more important than growth patterns. If you have an unhealthy infant who is growing slowly, take a good history and examination and think about nutritional status. Extra energy and protein are rarely needed or helpful, but there may be a role for other components that we're still studying, such as fatty acids. So in all infants, regardless of whether they're healthy or unhealthy, promote and support breast milk and breastfeeding, ensure vitamin D and iron. Micronutrient deficiencies are very rare, but they do occur, such as zinc. Avoid overfeeding with rapid growth, but also avoid underfeeding, and focus on nutritional status, not weight gain. Make sure we involve parents and educate them and involve them in making a feeding plan. And again, I just want to thank all the various funders for our research over the years and emphasize that improving brain outcome through nutrition in preterm babies is a team effort, and that parents must be at the center of that team. And finally, I thought I would just show you some of the many benefits of breast milk because I've been emphasizing its importance, particularly from a nutritional point of view. But now we can see that breast milk is used for a whole range of different outcomes. We know that buccal colostrum might be important, but people have been making ice cream out of breast milk, using it to treat acne. Cradle cap might be useful for sticky eyes. People are putting it in baby's bath. You can use it for making up cereal. Might be also interesting to use it on mum's skin. And we also know that bodybuilders are buying it off the internet. So lots and lots of different reasons why breast milk might be useful in society. But again, as I say, it's the nutritional aspects that I think we need to really focus on the neonatal unit. And I'm going to finish there, and maybe I'll have time to take some questions and answers in a subsequent session. So thank you very much, and I'll stop the recording there.